Good afternoon, everyone. We apologize for the delay, and we are still working on the camera so you can see us in the room. But we really appreciate your patience in joining us here today on behalf of the Developmental Disabilities Administration. My name is Rhonda Workman. I'm the Director of Federal Programs. And with us today, our other co-chair.
My name is Charlotte Whitaker. I am the other co-chair of the Waiver Advisory Council and a participant of the Community Pathways Waiver.
Thank you, Charlotte. I'm now going to turn it over to Dr. Smalls to share some of the housekeeping information with us.
Good afternoon. Thank you so much, Rhonda. Before beginning our meeting, we want to ensure civility for all of our meetings. The free expression of diverse viewpoints is a fundamental value of our group. This freedom carries the responsibility to engage respectfully, which means treating one another with dignity and respect and good faith. Uncivil behavior, disruptive actions, abusive language, threats, or harassment will not be tolerated and may result in the removal from the meeting. If you would like to use closed captioning so that you can read what is being said, click this button. Sometimes the transcription is not exact, but it's pretty close. All attendees are currently in listen-only mode, and your mics and cameras are turned off. Today's presentation is available in the handout section. Click here where you see the paperclip to download the presentation. If you have a question and you'd like us to read and answer it, click here where you see the question mark to add your question. If you would like to ask your question aloud during our comment section, please click this button to raise your hand. We will invite you to unmute during our public comment section of today's presentation. And now I'd like to introduce, again, our Director of Federal Programs and Co-Chair, Rhonda Workman.
Thank you, Dr. Smalls, and we're going to begin with Charlotte sharing the council purpose.
The purpose of the council is to provide input on DDA operated Medicaid waiver program, system design, service delivery and access to services, federal waiver assurances, ensuring access to Medicaid services, the access rule, and quality enhancement efforts and improvement strategies.
Thank you, Charlotte. Can you go to the next slide, please? And just a reminder, the council has ground rules, and so this slide is a reminder of our ground rules. We always want to assume positive intent. We want to speak one at a time. We want to use plain language, share information openly. We want to listen to different points of views, to stay flexible and open-minded, participate actively, engage respectfully and politely, and minimize distractions. Now we're going to turn it over. Deputy Secretary, would you like to say a couple of opening words?
Good afternoon. Welcome, everyone. Thank you so much for joining us this afternoon. As you heard, we had a few technical difficulties, and since we're starting so late, we're going to go ahead and get started with our very robust agenda. Thank you again for joining us this afternoon.
Thank you. Can you go to the next slide, please? So here's our agenda for today. We're going to start with the approval of the June minutes, give you several updates related to DDA. Then we have our People with Lived Experience work group that's going to share some information, followed by our recommendation work group, and then we'll open up for public comment. Next slide, please.
For our June meeting minutes, would anyone like to make an amendment to the minutes? If there are no amendments, would someone like to make a motion to approve the June meeting minutes. Yeah, and then a second.
Does anybody want to second the motion to approve?
I'll second it, Rachel.
Second,
Thank
the
you.
motion.
Great, thank you so much. Let's go to the next slide, please. So we're going to jump right into a variety of updates that we'd like to share with you. If you can go to the next slide, please. The first update that we want to talk about is our meeting frequency. In the next slide. We have a lot of great and exciting things going on. And to continue the conversation and input, we'd like to move to monthly meetings. And so we'll begin this effective now, so we'll be meeting every month. These are the dates of our future meetings. It still falls on the third Thursday of the month, same time. We will be updating our website to reflect this information, and we'll also identify the in-person meeting locations. But really excited about everything going on and want to continue the discussions with the group. Yes?
On 2 of those dates, you have community webinars planned already. Are you changing those?
Yes, we will be making adjustments to the community webinars to make sure that we can support the council and also have those opportunities for stakeholder engagement.
Great.
Next slide, please. So Charlotte shared the purpose of the council, so we're going to go through and give you some updates related to the various components of the purpose of the council, starting with our DDA operated Medicaid waiver program design. Next slide, please. So the first update we wanted to share was on the DDA waiver amendment. And so, as you know, if you've been following us with our communications that have been going out, the amendment process concluded, our public input process. We received comments that were in support of the various amendment proposals. We also received several alternative suggestions to our proposals. And we did also receive some respectful opposition to what we had proposed. We received several recommendations that were kind of outside what we had originally proposed, which we would like to engage in further discussions and stakeholder input. And so for those items, we did not put in the amendment. We didn't accept those, but we have flagged them for further discussion. And I'll share some of those examples with you today. Next slide, please. So this slide shows some of the proposals removed from the amendment. They include the removal of awake and alert overnight staff language, removal of support broker and day-to-day administrative support's 40-hour per week limit across all people they support, and the removal of the exclusion of day trips from transportation services and respite care. The DDA initially shared that we would be removing these proposals during our July 2nd, 2025 DDA amendment stakeholder engagement webinar, and so just to continue to share that we did take them out of our proposal. Next slide, please. Additional proposals removed before submission to CMS included the removal list of meaningful day service training requirements. We had some questions that some of the stakeholders had shared with us. So we kept the existing language that's been in the waiver that notes that direct support professionals must satisfactorily complete required orientation and training designated by the DDA, which is noted in policy stat. We have removed the proposal to authorize services for up to 6 months while a nursing care plan is being developed. Delegated task cannot be provided without a nursing care plan, as per the Code of Maryland regulations for the Board of Nursing under delegation of nursing functions. That means that we cannot then authorize services without a nursing care plan. The DDA may authorize supports and support participants that are new or in services that has a behavioral need for up to 6 months while a behavior support plan is being developed. So we've continued that proposal that we put in there. We added that the DDA may authorize nursing support services in an emergency revised plan for participants in services who do have a specific documented health and safety need to immediately support that nursing care plan being developed, and then therefore we can support dedicated supports for those individuals. And we also removed the proposal for emergency or unplanned departures an overtime request form process. The proposal related to the use of legally responsible persons, legal guardians, and relatives as paid staff to exceed the 40-hour limit. So we originally had proposed using a new overtime request form and having exceptions related to emergencies and unplanned departures that we took out of the waiver. Yes, ma'am.
Just to clarify. Just a clarifying question, does that mean there will be no exceptions over 40, because there's currently kind of an exception process, this proposed a little bit of a different process, does the removal mean there will no longer be any exception?
Yes, so per the amendment proposal, we have removed any language that related to otherwise authorized by DDA. So we will maintain the current limit that's noted within the waiver program. Specifically for these groups of types of providers will be up to 40 hours per week. Next slide, please. Some additional updates related to our amendment submission relates to a substitute judgment form. As you may recall, we had shared in our webinars that a substitute judgment process is required by CMS when legally responsible persons, legal guardians, or relatives have decision-making authority over the participants' services. Our initial proposal was for the use of a supported decision-making agreement. So we have removed the requirement for a supported decision-making agreement and noted in the waiver that we would utilize a substitute judgment form. On July 28, we met with the DDA Waiver Advisory Council Waiver Recommendation Work Group, and we asked for input on how this can be operationalized, and we hope to hear some information again today. Next slide, please. Some additional proposal updates that we submitted with the submission was we added language related to housing support services, specifically noting that these services included both direct and indirect supports, and we added the virtual support service delivery option. We added that first aid must include a hands-on in-person component requirement. This is similar to the language requirements for CPR. It's also required for first aid, so we added that. And then we also added an opportunity for individuals who have a emergency medical technician or an EMT certification as an alternative to meeting the first aid and CPR training requirements. Next slide, please. So I mentioned there were several suggestions that we received that we wanted to further explore with stakeholders, so we did not include them in the amendment. And so these are a few of the examples of some of the suggestions or alternative recommendations we received. We received a recommendation about adding an independent scoring mechanism and validating tools to authorize dedicated hours. There was also recommendations to look at Medicaid provider enrollment requirements and maybe expanding those. Also, a recommendation for the creation of a behavioral support plan template, development of provider code of conduct. As you know, in the waiver, we have support broker code of conduct, and so recommendation to expand that to all providers. Recommendation related to exploring aging and future planning strategies and supports. And also a recommendation to explore ways to share the quality improvement organizations information that they have, specifically with participants and family members. So these are just some of the things that we can further look at and explore. Next slide, please. And lastly, related to the waiver amendment, we have posted track change documents related to the actual waiver submission. This slide includes a link to our direct page that you can look at. When you open the submission documents that we have, anything that is highlighted in yellow reflects a change. And so you'll still have the red text and strikeouts, but yellow will indicate that it was a change from our initial proposal that everybody was looking at. So our next steps, the Center for Medicare and Medicaid Services, the federal government entity that we work with, is reviewing the amendment proposal. We will be answering any questions that we receive that will go directly to our Medicaid office first. We are working on information and training for all stakeholders, so you'll be hearing some information related to that coming out from us soon. And again, our amendment effective date has a proposal of October 6th. So before we go to the next update, I just wanted to pause and see if the council members had any questions related to the information that we just shared.
No hands raised.
I'm going to now turn it over to Robert White, our Chief Operating Officer, to share an update on the next slide.
Thank you, Rhonda. Good afternoon, everyone. My name is Robert White.
John Paul Lavallee.
We're pausing for a question.
You can go ahead and ask this question.
John, you can go ahead and ask your question.
He's a council member. He should be with him. John, I'm going to ask John to ask his question.
John, you can ask your question. You've been unmuted. While we're waiting for John to ask his question, I would like to take this opportunity to thank everyone on behalf of the department for your interest in the Maryland Intellectual and Developmental Disabilities Sustainability and Equity Committee, better known as MIDSEC. This important committee will play a key role in advancing both sustainability and equity in DDA programs. We're excited to share that we received more than 175 applications. The review process will soon begin, and we will continue to keep the DDA community updated as progress is made, including other ways that everyone can get involved. Thank you once again for your commitment and interest in this effort. I will now turn the presentation back over to Rhonda to talk about service delivery and access to services, unless John is ready to ask his question.
So we did also receive a question from Emily, another council member that she put in the chat. Emily, I'm happy to read it for you. Emily says, would the conduct extend to the delivery of services from our community coordinators and support planners, especially relating to constant changes in personnel and quality of services and self-directed services? I believe this relates to our comment that we could explore further code of conduct for providers, and that could absolutely be something that could be explored. All right, you can go to the next slide, please. So we'd like to share some updates related to service delivery and access to services. And we'd like to invite our partner from the Office of Eligibility, Keisha Shaw, who is the Deputy Director of Eligibility, overseeing the Eligibility Determination Division, to share some updates. If you go to the next slide, please, and make sure Keisha's mic is open.
Sure. Yes.
Good afternoon, everyone. My name is Keisha Shaw, the Deputy Director of the Eligibility Determination Division. Rhonda, is it okay to share my slides?
We have the slide that we had. If you have other slides, if you'd like to share.
I'll share them at the end, and you can share them with the participants.
Okay, thank you.
So just, sure, really quickly, just a general update regarding people and EDD's recruitment efforts over the last couple of months. There has been a reduction of the 50% vacancy rate in EDD since November of 2024. It is currently, as of July 2025, the vacancy rate is
Keisha,
at, yes.
Keisha, excuse me, is there possible that you could get closer to the mic or project a little bit?
Let me see. My mic is turned all the way up. Is this better?
Is that better from the back? Go ahead, Keisha.
Yes, we can hear you.
Yes, Keisha, go ahead.
Is this better?
Yes.
Okay. My laptop is in an awkward situation, so please bear with me. Since November, as of July 2025, the vacancy rate is at 16%. As many of you are aware, during the 2025 legislative session, the Maryland General Assembly cut some positions that were vacant within EDD. Medicaid has reallocated positions to support continued recruitment efforts within EDD. So we're hopeful that we will be allotted additional positions in the near future. We also want to announce that just last month, we onboarded a training services specialist who will be supporting new eligibility associates and providing training updates regarding new or modified regulations and policies and system modifications, federal rules, etc. Our ongoing efforts to strengthen the EDD team includes cross-training team members, and we are continuing to standardize our training materials, system access to training, and our internal documents to assist team members with processing cases timely and accurately. With regards to systems and processing, in December of last year, the department implemented an electronic method for applicants and recipients that have been denied or their Medicaid services have been suspended or reduced to submit an appeal online. As of fiscal year 2025, the department had received 2,669 Medicaid appeals, of which approximately 800 of those were EDD appeals. So we're hopeful that applicants and recipients will begin to utilize the web-based request for fair hearings and appeals. In addition to the enhancement, the web-based ability to submit appeals, EDD is working on an electronic submission method for supports planners, CCSs, applicants and recipients to submit redetermination applications and verifications to EDD via the web. We are also working to implement the DDA waiver consolidation on the MD worker portal. And we have recently implemented some reports, specifically an application report on LTSS Maryland, as well as an attachments report that notifies EDD when CCSs or supports planners have uploaded documents to LTSS Maryland. And we've also recently implemented a report to capture when authorizations to participate or ATPs are submitted to EDD. That concludes our updates for people, processes, and systems. Does anyone have any questions?
So we do have one question for the proxy for Mr. Baker. It says, I and others have spoken to continue to struggle to submit redebts using my MD Think. It is very glitchy and problematic. Can you please simplify it to make it more user-friendly? People should not be reduced to sending sensitive financial documents via email.
We wholeheartedly agree with you. I actually have an item on the roadmap for MD Think for the consumer portal to increase customer and efficiencies, along with a number of items on the worker portal to assist workers. So we're hoping to have some improvement in the next year or so.
Great, thank you. Any other
But
questions?
please, I can't stress enough, please try to continue to use the consumer portal. Are there any other questions?
I think those are the questions that we have right now from council members.
Okay, and I'll share the presentation, Rhonda, so that you can send it.
Great, thank you so much.
Sure.
Can we go to the next slide, please? So our next update relates to federal waiver requirements. Can you go to the next slide?
Can I have a question about the previous thing?
Sure. Can you identify yourself?
John
John
Paul.
Is it John Paul? Oh, yeah. Yeah, go ahead, John Paul.
Will this affect the budget? If it was already approved before the date, will this new change goes into effect? Will it still be approved, or will it have to be amended? The budget, like things in the budget.
I'm sorry, John Paul, I'm not quite following you. We were talking about the eligibility, the Office of Eligibility Services and Eligibility Determination Division. Are you going back to the waiver update?
Oh yeah, I was going back to earlier in the meeting.
Okay.
I'm sorry.
Oh, no, absolutely. I just want to make sure that I can answer your question. So the amendment, the consolidation, meaning the family supports participants and community supports participants will be transitioned into the community pathways waiver, and their budgets and their approved services and plans will automatically be transitioned. So it will not impact their services or their budgets.
Okay, thank you.
Thank you.
Rhonda, and we have one from
So-
Zanetta.
So I also have two questions. One I put in the chat. Currently, when agencies apply for multiple people's waivers, they have to have a separate email and a separate phone number.
Excuse me, can you identify yourself?
I'm sorry, I'm Zanetta.
Zanetta, we'll hold public comment to the end. At this
Okay.
point, we're just taking questions from our council, so thank you so much.
Okay.
So,
Okay.
don't unmute anybody.
So-
We've called them.
Wanted to give you some updates related to federal waiver requirements. Medicaid home and community-based services have federal waiver assurances. And so I'm going to give a little overview of the 6 assurances. And then we have our partner from the Office of Long-Term Services and Supports who's going to share some more information specifically about the administrative authority. And what we'll do for each council member is we'll highlight one of the assurances and share some additional information. So the waiver federal assurances that we have on our screen, the first one is administrative authority. And this means that the Maryland Medicaid office is responsible for the operation of waiver programs. The Developmental Disabilities Administration is considered an operating agency. So we work on behalf of Maryland Medicaid to operate the programs. The second assurance relates to level of care. And for this assurance, the state must make sure that people that are participants in the program need a level of care consistent with care provided in an institution. For the DDA operated Medicaid waiver programs, the institutional comparative is considered individuals with intellectual and developmental disabilities in an intermediate care facility. For us, that would be referring to the Holly Center and the Potomac Center. The next federal assurance is referred to as qualified providers. And so the state must have a system for assuring that all waiver services are provided by qualified providers. That includes both service delivery models. So both the self-directed service delivery model and also the provider managed model. Next slide, please. The additional federal waiver assurances includes service plan. And for this assurance, the state must review and approve person-centered plans for waiver participants. The next one is health and welfare, and the state must have a system for assuring waiver participants' health and welfare. And the last assurance is referred to as financial accountability, and the state must have a system for ensuring financial accountability of the waiver program. I'd now like to turn over to Elisa, who's going to help and share some more information related to administrative authority. So if you go to the next slide, please.
Thank you, Rhonda. Hello, everyone, and good afternoon. My name is Elisa Jones, Assistant Director in the Office of Long-Term Services and Supports, or AKA the Medicaid Office. The Medicaid Office at MDH is the Office of Long-Term Services and Supports. It's the state Medicaid agency within Medicaid that oversees the administration of the DDA operated waivers. The DDA administers the Community Pathways Waiver, the Community Supports Waiver, and the Family Supports Waiver, as you all know. The OLTSS, or Office of Long-Term Services and Supports, serves as the point of contact with the Centers for Medicare and Medicaid Services, or otherwise known as CMS. We're the point of contact with programmatic expertise and support provided by the DDA. In this capacity, the OLTSS oversees the performance of the DDA, designated as the operating state agency for the waiver program, as Rhonda just mentioned. Being the administrative authority requires us to look at performance measures related to, as noted on the slide, the annual quality reports. The DDA prepares the annual submission for submitting quarterly quality reports. So through the year, we collect them quarterly and we submit it to CMS annually. It is the report of the status of the waiver program's performance measures and includes the discovery findings, remediation strategies, challenges, system improvements associated with each waiver assurance, including level of care, service plan, qualified providers, health and welfare, financial accountability, and administrative authority, as Rhonda just went over. The report includes any barriers to data collection and remediation steps. Other performance measures for the administrative authority include ensuring providers have signed Medicaid provider agreements, collaboration with the DDA to review and approve policies, holding at minimum quarterly meetings with the DDA, reviewing Type 1 Priority A incidents of abuse, neglect, or exploitation, and reviewing the Office of Healthcare Quality's on-site death investigations. I'll turn it back over to you, Rhonda.
Thank you, Elisa. Emily had a question that we're going to circle back to, but before we go to that, any questions about the federal waiver assurances? So Keisha, this may be a question for you. Emily is asking, as it relates to appeals, can you talk about the process to submit appeals and that there is no one to answer questions? The answering system is outdated. Is there a better streamline to gain assistance and support on appeals in a timely manner? So Keisha, would you like to talk about the online appeal process?
I can let me resituate my laptop so you can hear me. I can go over the online appeal process at a high level. However, that's not a function that is managed by EDD. So based on the information I'm aware of, when an individual submits a request for an appeal via the new form, that individual will receive confirmation that the appeal has been received. Additionally, during the appeal process, though, the recipient or authorized representative should be having what's called a pre-hearing conference to discuss the appeal and to gather additional information regarding the appeal. Are you indicating that that's not happening?
That's not happening.
She said it's not happening. Emily replied that it's not happening.
Okay. I can take that back and share it.
Okay, great. So Keisha will take that back and share that, and we'll see what other system improvement enhancements can be. Any other questions on federal assurances? or the other topics. Okay. Can we go to the next slide? So one of our federal assurances we talked about was qualified providers, and you heard that we are submitting reports to Elisa's office to share information. So Nicole Crawfiller is here, our Director of Quality Enhancement, is going to share some information specifically about the performance measures for qualified providers.
Thank you, Rhonda. As Rhonda and Elisa both stated, DDA is required to complete and submit our quarterly quality reports to the Office of Long-Term Supports and Services. DDA is to maintain 86% compliance on all performance measures. Otherwise, DDA is required to develop remediation strategies on each performance measure that does not meet compliance standards. The DDA has not met compliance in one area, which is the qualified providers' performance measures. Here on the slide, there are 4 performance measures DDA has not met compliance with within the community supports and community pathways waiver for the first 3 quarters of fiscal year 2025. DDA licensed and certified providers are expected to follow COMAR 102202B, which states a provider's application is required to be submitted 60 days prior to expiration of its existing license. Many times we are seeing that providers are late in submitting their application. This can be from 1 business day up to 90 days. The DDA Regional Office Provider Services teams have continued to reach out to providers with reminders. DDA has shared in provider meetings and webinars of this requirement. The DDA will continue to strategize new ways to help increase compliance within the qualified providers' requirements. Next slide.
Any questions on qualified providers and our performance measures? So now I'm happy to introduce our partners from the Hilltop Institute, Kristen Dale, who's going to share some information about cost neutrality.
Thank you, Rhonda. Good afternoon, everyone. My name is Kristen Dale. I'm with the Hilltop Institute. Next slide, please. And so as part of our work with the DDA and the Medicaid agency, we do provide some estimates for cost neutrality. We thought it might be helpful to give sort of a big picture overview of the DDA budget and how it sits within the Medical Care Programs Administration, as well as the participants who are connected with each of those budgets. So you can see that the DDA budget on here is about 17% of the total of the Medicare program administrations, the Medicaid agency and DDA budget combined. And then when we look at the participants, the total Medicaid programs support about 1.8 million participants in fiscal 25, and of those, about 1%, so about 19,000 were DDA waiver participants. Next slide, please. So yes, if you go back to the last slide, the total, it actually shouldn't be dollars, and it just should be 1,843,511 is the total. Okay. Thank you. Next slide. And just for reference, these figures and the budget allocations were all from the Maryland Department of Budget and Management's website. Looks like the link was removed, but we could share that. And so as part of their website, they also give a breakdown of the budget allocations. And so just for quick reference, this slide shows those services within the DDA waivers and the budget allocations. And so you can see the biggest piece of the budget is allocated towards residential services. Next slide, please. And so just for some more context and, for quick reference, we thought it'd be helpful to see these DDA waiver participants, who are receiving services and kind of their overall characteristics and demographics. And so you can see we have the data broken down in the aggregate across the 3 waiver programs, as well as within each of the 3 distinct programs. So you can get a good sense of the population that's being served. In general, it's mostly male. You can see the age groups. Most individuals are over 21 per the program requirements. You can see the breakdown by the DDA regions. Next slide, please. This also gives a good sense of dual status, so this would indicate those individuals who are receiving services who are eligible for both Medicaid and Medicare services. The service delivery model, the breakdown between self-direction and traditional. So you can see most participants are in a traditional model in fiscal 25, and then some detail on Medicaid eligibility groups, so how these individuals are eligible for Medicaid. Next slide, please. And so as we start getting closer to talking about our budget neutrality, this is a great visual of how the average annual expenditures per DDA waiver participant have increased over time or trended over time. You can see each of the 3 waiver programs are represented. You can see the increase in services over time. And then for reference, we've added the budget neutrality figure for the waiver for fiscal 26, the current year, which is $216,859. Next slide, please. So this slide is really a reference slide. For those of you who have dove into the waiver amendment and the waiver authority, you'll notice that there's lots of factors and different nomenclature to capture the different pieces of costs and number of unduplicated waiver participants. And so as you're reading through or you hear discussions, Factor C is really focused on the unduplicated waiver participants during each waiver year. This is a key piece that's used in estimating. So as we look at the number of people who are projected to receive services, this helps to influence the estimates for utilization at each of the different service levels. The Factor D and Factor D prime are related to the cost of the participants in the program. Factor D is for those services that are home and community based and offered through the waiver program. And then Factor D are all those other Medicaid costs that the participants incur through their participation in the waiver program and as a Medicaid recipient. And then the Factor G and G prime are related to the institutional costs. And this is where we get to that cost neutrality factor. And so these are costs for individuals who would otherwise be institutionalized other than receiving waiver services. And so for the DDA waivers, we use costs for individuals who are in the ICFI ID facilities in Maryland. And we look, similar to D&D Prime, we look at those costs incurred as part of their institutional stay, and then also look at other Medicaid costs that are billed for these individuals outside of what that institutional payment looks like. So when we go to the next slide, slide 39, this gets into the actual estimates that are included in the waiver. And so if we look at the cost neutrality, we're focusing on Factor G and G prime. And then those are added together for a total, and this is what gets to the institutional cost. And if to real high level in terms of how we get to these figures, what we do is we look at the actual expenditures for those individuals in the 2 facilities in Maryland. We pull all their costs for the year, look at both those institutional and Medicaid costs. We drill it down into a per member per day costs, and then we're able to annualize it to compare it to the waiver using the average length of stay in the waiver. And then these costs are trended annually to help project forward. And then finally, for reference, we thought it would be helpful to show just a picture, a snapshot of what the current waiver participants' active approved plan budgets look like. So you can see we pulled all of the active plans that were available in July. There's about 18,618 plans. You can see the total budget approved of all of those plans. And if you think back to where we started, this dollar figure is over the budget allocation for DDA for the year. And then when we drill down, you can see that plans range from just a couple $100s all the way up to $2 million in terms of approved budgets. And then when we kind of break that down and look, so we have all these approved budgets and we have our cost neutrality figure, where do our plans fall? So you can see currently we have 48% of the plans falling below that cost neutrality figure and 52% falling above that cost neutrality figure. And so this is really important for reference because as discussions continue when we move forward, it's important that we maintain that cost neutrality for the waiver. That's a federal requirement. And so making sure that we've got plans approved in a way that can help sustain access to services for everyone while we maintain.
So we have a few questions.
Thank you. This was really helpful. I just have a couple questions for clarity. The total number of DDA waiver participants is different on every slide. So the first slide, you have 19,096. On the characteristics of DDA waiver participant slide, you have in the unduplicated amount 19,152, and then in the big chart 18,075. Is that just reflective of people when you pull the data and people going up and down?
Yeah, so some of the slides show unduplicated and some show duplicated. I will also say that oftentimes there are participants who are enrolled who don't receive services. And so sometimes when we're reporting on dollars and characteristics, it's of those individuals who are enrolled and receive services. So.
That's what I thought. I just wanted to make sure. And then also just for a point of clarity on the last couple of things you talked about in terms of budget neutrality. I'm not going to try and explain this, but it's my understanding that we don't just use the 216,000, and obviously we don't use people's budgets because we know people have higher. Can you just explain quickly one more time for those of us in the room that have to keep hearing it, how we sort of average that to still we are in factor D and D together below the 260? Does that make sense?
Sure. So the waiver has to remain cost neutral in the aggregate. And so that's when we look at that last slide and we're looking at the plans above and plans below. That's how we're maintaining the cost neutrality because we have some participants who receive a lot less services than others. But as a whole, the waiver has to remain cost neutral. So when we pull the figures to help the DDA report, we're pulling all of the services and divided by the participants to get that aggregate average.
And then Matt has a question, and we'll look online.
Slide 34 with the budget breakdown, the top categories, was that based on the individual's budget as approved, or is that based on expenditures?
Oh, sorry. So thanks for the question. This is actually on the Department of Budget and Management's website. So this is how the budget is allocated for DDA at the state level. So this isn't based on any actuals. This is based on budget allocations.
Very good, Matt.
What was that? What is that?
It's like, yeah,
Yeah,
the year.
it just wasn't any, it wasn't that.
So what Kristen's saying is this is what we have in the DDA budget. This is the money they gave us to support these different cost centers. Any other questions from council members before we look online? Oh, yeah.
Back to cost neutrality, this is a bigger question. I'm not just the data, so if it's not for you, I can say that. This is one way to determine cost neutrality, but there are other ways. If we wanted to do another waiver amendment, I'm not suggesting we do that. Am I right? Like some states use a different method for determining cost neutrality.
Yeah, so there are different methods that you can use for cost neutrality. Kristen shared we use the aggregate, which means we take everybody, we look at everybody's cost, and so total we all have to be cost neutral. And she shared that there are some people below, some people above, and so we want to be cost neutral overall. Other programs use an individual cost neutrality. Matter of fact, I believe all our other HCBS, home and community-based waiver programs in Maryland, not all. Some of our other Medicaid programs in Maryland use individual cost neutrality. So what that means is each individual's plan has to be below the institutional cost. Marlene, did you want to add some more?
Minor point of clarification, the individual cost neutrality can be at or below the program's cost neutrality benchmark, and then the state also looks at it in the aggregate, because there are instances in which there is some flexibility for the individual cost neutrality. The program in its entirety must be cost neutral.
Just go with the line for council members. Okay, we're going to go to the next topic, and our next topic relates to a new federal rule that has come out. It's called Ensuring Access to Medicaid Services. We tend to refer to it as the Access Rule, and we're going to turn it back over to Elisa to share some information about the Access Rule, giving us an overview of the different provisions and talking about a few of them specifically.
Hello again, everyone. It's Elisa Jones. In the next 3 slides, you'll see a list of the Ensuring Access to Medicaid Services measures. Let me start over. The CMS has directed the agency to identify ways to continue to expand the availability of affordable health care, to improve the quality of coverage, to strengthen benefits, to help more Americans enroll in quality health coverage. The Ensuring Access to Medicaid Services, or the Access Rule, final rule, advances access to care and quality of care and will improve health outcomes for Medicaid beneficiaries across HCBS services like waiver programs. The OLTSS, or Office of Long-Term Services and Supports, is evaluating the provisions in the Access Rule to ensure compliance ahead of the respective applicability dates. And over the next slides, I just listed out those rules that we're looking into. And I'm just going to read through them very quickly. The first one is the Payment Rate Transparency Publication. This requires us to publish all Medicaid fee-for-service rates on our website and make it accessible to the public by July of next year. The payment rate disclosure is we are required to publish a payment rate disclosure that expresses the state's payment rates as the average Medicaid fee-for-service rate, separately identified for payments made to individual providers and provider agencies, if the rate varies, also by next July. The grievance system, the state must establish a procedure under which the beneficiary may file a grievance related to the state or provider's performance of the activities. This is also due by July. The Interested Parties Advisory Group. The state agency must establish an advisory group for interested parties to advise and consult on provider rates where payment rates are made to the direct care worker and for self-directed model and agency-directed services. Because we are a money follows a person state, this was advanced to this year. So we're actually standing this up right now. We've established a web page and we've taken applications for interested parties to join this advisory. Next slide, please. The Home and Community-Based Services Quality Measure Set is another rule we're looking into. The state agency must establish home and community-based services quality measures for Medicaid. And because we're an MFP state, this was also advanced. We're looking to put this in place in September, and I'll talk more about this one in a minute. The next one, the person-centered service plans. The state agency must ensure person-centered planning aligns with requirements of this final rule, to include the person-centered planning process requirements, community setting modification requirements. Community setting modification requirements is repeated, and annual PCP review requirements. This is due by July of 27. The incident management system, assurances that the state operates and maintains an incident management system that identifies, reports, triages, investigates, resolves, tracks, and transcritical incidents, also due in July of 27. And reporting requirements. The agency is required to report on safeguards to assure that eligibility for Medicaid-covered care and services will be determined and provided in a manner that is consistent with the simplicity of the administration, the best interest of Medicaid beneficiaries, to assure the correctness and verification of such reports, also due in July. Let me pause there for a second. So just to distinguish, the reporting requirements required here is a little bit different from the current reporting requirements we talked about earlier. We're currently doing for the waiver application via the annual utilization expenditure report. Some may be familiar with the 372 report, and also with the quality reports and evidence-based reports. These are standard reporting that is required anytime you run an HCBS waiver program. This new reporting requirement is specific compliance reporting according to the federal regulations to cover the incident management system, the critical incidents, person-centered planning, the waiver's impact on the type, the amount, and cost of state plan services, access to report to include waitlist and enrollment times, data on access to homemaker services, home health services, personal care and rehabilitation services, payment adequacy, and data specific to the Community First Choice program. So these are additional reporting requirements. Next slide. The website transparency requirement. The state must operate a website that provides the results of those reporting requirements I just talked about. And this is also due in July of 27. And then the home and community-based services payment adequacy. This assures that payment rates are adequate to ensure a sufficient direct care workforce to meet the needs of beneficiaries and provide access to services in the amount, duration, scope specified in the beneficiary's person-centered plan. Also due in July of 27. Next slide. Okay, so I just want to pause and talk more about the home and community-based services quality measure set requirement. The HCBS QMS is a set of nationally standardized quality measures for Medicaid-funded home and community-based services used to measure the quality of experience. It's intended to promote a more common and consistent use within and across states of nationally standardized quality measures for the programs. This creates opportunities for CMS and the states to have comparative quality data on home and community-based services, including for identifying and addressing disparities in the programs. CMS has identified specific measures for which reporting is mandatory. The money follows the person state, which Maryland is. Our first year reporting is this year. For the DDA operated Medicaid waiver programs, they'll continue to use the National Core Indicators Survey for individuals with intellectual and developmental disabilities. The other access rule I want to touch base on is the grievance and fee-for-service systems. Currently, grievances are captured using the Reportable Events Policy, or PORI, Policy on Reportable Incidents and Investigations. The state now must establish a procedure for which the beneficiary may file a grievance related to the state or provider's compliance with person-centered planning through the HCBS setting requirements. The system needs to be established by July of 26, pending any changes from the federal government. Right now, we're working to establish this single point of entry and oversight for all grievances to OLTSS. And that's a very brief overview of the ensuring access rule. I'll take any questions.
Any questions in the room? I don't see any online either. So we'll continue to provide updates related to the access rule, and as Elisa shared, the National Core Indicators are performance measures that we currently use. We currently use that tool, and in our waiver submission, it expanded that to include some additional elements from the National Core Indicators. So now we'd like to turn and talk a little bit about some of DDA's quality enhancement efforts and improvement strategies. So if we go to the next slide. And so we have a number of updates. We're going to hear from Stephanie Jones, DDA's Director of Innovation, Dr. Meg DePasquale, our Director of Clinical Services, and then I'll share an update related to the Self-Directed Services Manual. So first we'll hear from Stephanie.
Good afternoon. The College of Direct Supports is a resource for providers to have a centralized platform where the direct support professionals can participate in required training and career development. DDA recognizes that the roles of direct support professionals have changed over the years, from simply caregiving to supporting people with developmental disabilities to build their lives through community inclusion, competitive integrated employment, and living and housing outside of traditional services if they choose. The learning platform was developed to ensure that direct support professionals have access to the training needed to be successful in this role. As they have a path to career advancement, the DDA has partnered with Seek, a DDA licensed provider, to provide a pilot platform which has been merged into the new platform administered by the University of Minnesota. The learning platform includes the required training to earn certificates as a DSP1 and then a DSP2. These trainings consist of information about persistent planning, communication, daily living skills, health and safety, competitive integrated employment, and much more. Currently, there are 24 individual organizations enrolled in the platform. 1,057 learners and administrators are enrolled into this platform, and 7,718 lessons have been assigned within the platform. So next, I have been asked to discuss a little about our employment data. So twice a year, the Institute of Community Inclusion sends out a survey on behalf of Maryland DDA to see what meaningful day in employment services people are engaging in, and how how they are using. The survey is done for all states that are a participant in the State Employment Leadership Network, in which Maryland is a member of. This data was used by the DDA in previous years as DDA was transitioning payment platforms from the PCAs to LTSS. It was used to help develop more comprehensive, meaningful day and employment service definitions to ensure people receive DDA Medicaid services that are flexible and have access to a variety of opportunities to build their best lives as they define.
Any questions about direct course or employment data? Rachel.
Thank you. Stephanie, I think you mentioned 24 organizations were on the platform, the direct course platform. Is that available to all organizations, or that's the pilot right now?
No, that's available to all DDA licenses.
Okay. And that is if they choose to use the DSP 1 and 2 certification rather than their own training, right?
It's okay. Yes, it's a choice. It's just one resource that we're providing to help training to be more accessible to
Great, thanks. And then my last question, the employment data, just so I'm clear, you are still using them, Institute for Community Integration. ICI, I knew that, I just couldn't get all the I's. You are still using them, it's, okay, I couldn't tell from the way.
Correct. It's for the people online. Yes, we are still using them.
Great, so we're gonna turn it over to Dr. Meg DePasquale to share some updates related to positive behavior support.
Hi, good afternoon, everybody. Positive Behavior Supports is a framework that includes tools and strategies for improving quality of life and decreasing challenging behavior. These tools and strategies are divided into 3 tiers. Tier 1 involves teaching everyone to use proactive strategies and to work together to define a specific value that reflects to reflect values that people feel are important. Tier 2 involves identifying individuals that need a little more support and then providing that support, such as check-ins or having them be a part of a social skills group. Tier 3 provides highly structured, individualized support for these individuals that have significantly challenging behaviors, as we would call that a behavior plan. Since 2019, the DDA has been implementing an organizational-wide positive behavior supports initiative. This initiative aims to increase the number of providers who utilize this approach and these are providers within each region. The organizational-wide approach is a crucial way as it moves beyond a train and hope model, which is when we send a few staff to workshops and then expect significant change. Currently, we have 2 cohorts that are actively involved in this initiative, and our 3rd cohort will be starting up in September of 25.
Just to clarify, the DDA pushes out information for people who are interested in being part of the cohort that they could apply. Is that correct?
Yes, correct. We have an application process, and then there are several webinars to explain the process for being a part of these cohorts, and that information is put out through our various different communication processes through the communications department. So that information is put out throughout the year. If anybody's interested, they can attend those webinars and then get more information.
Any questions? Nicole, any questions online? Great. So the last update relates to the self-directed service manual. And so we have shared the manual with the Waiver Advisory Council. Just a reminder, we're looking for input from all members. So we're looking for everybody to share their thoughts related to the manual that we're looking for by tomorrow. The deadline was for tomorrow. We have also shared the information with our financial management counseling services providers. We've also shared it with a few other advocates to get some additional information and feedback related to that.
Rhonda, with regard to the manual and its proposed changes, how can we be assured that the changes aren't going to in any way negate or water down the Self-Directed Services Act of 2022? And there's obviously concerns with that, and if there are concerns related to specific proposals, how are we going to work together to address them? Like, what is the process for us moving this forward?
Right, absolutely. So please share that with your thoughts and anything that you see as a concern related to that. Some of the updates are really related to the amendment. So this is looking to go to an effect October 6th in line with the amendment, and then to provide additional information and clarification. We did receive, prior to sharing the suggested changes with you, some feedback from another self-directed advocacy organization that shared that with us, and we continuously get feedback. So please share exactly that so that we can look at that and support exploration.
Thank you so much for that question, Beth. And I just want to assure everybody that we continue to support self-direction. We are always looking at the act to make certain that any of our actions are not in conflict with that. So if you are hearing or you're feeling that we are in any way running afoul, as Rhonda said, we definitely want to hear from our advocates and partners on this. We really want the program to operate the right way, and it's all about the participant first.
Can we go to the next slide? All right. Long-term services and support, or LTSS Maryland updates. We'd now like to turn it over to our colleague, Nicholas, who's going to share some information related to LTSS.
He's not. He said he's muted. He's not on the call. He's saying he's muted.
Maybe we'll follow up and see if we
Last
can
name starts
reach
with a
him.
Q.
Dr. Smalls, while we're reaching out to him, if we can go to slide 51. And now we'd like to have the update from people with lived experience group.
Thank you, Rhonda. Well, so the lived experience group has been continuing to meet, and we are currently working on making sure that all of our members understand the self-direction manual and that they are able to submit their public comments as they would wish to. We also have a statement written that I'd like to read real quick. For many of us in the lived experience group, this council has been a valuable opportunity to better understand the waiver and how government systems operate. This knowledge is essential for disabled citizens navigating daily access to services. While we are grateful to participate, the pace and process have been challenging. We are often asked to review lengthy, complex documents on short deadlines. Though we recognize some government constraints are unavoidable, these conditions have sometimes created confusion and limited accessibility for members with different needs. A shared concern among our group is how proposed changes could affect our rights and autonomy. When seeking clarification, we are often met with responses focused on participant safety. While safety is important, such replies dismiss our questions and unfairly force us to defend our compassion for others. Autonomy and safety should not be in conflict. This council has the ability to ensure both. As Judith Heumann, a leading disability rights activist, wrote, when institutions don't want to do something, to claim that something is a safety issue is an easy argument to fall back on. It sounds so benign and protective. How could caring about safety possibly be wrong or discriminatory? Let us work together to ensure that her words remain a lesson from the past, not a description of our present.
Thank you, Charlotte. And could you clarify the questions and that you're getting related to that? Is that happening in some of the work groups and some of the discussion about the waiver recommendation?
Yeah, yes. They have come up in some of the work group discussions with the whole group as well as our lived experience group specifically. And I think a lot of the conversation was based off of needing clarification or misunderstandings about a lot of the, or just about some of the policies that were being proposed.
Great, thank you. And I'm happy to support, join the group, answer questions and those type of things. So we can talk some more to see how myself, other DDA members can help to support, to be there to clarify information provided in different formats and have discussions so that we can make sure that we're clearly communicating as accessible and plain language as we can to support questions.
Yeah, that would be great. And I think also we want to bring forth, our specific needs so that, because we know that we all want to accommodate to make sure that everyone can access it, but because many of our members have different ways of communicating, sometimes finding new ways to allow them to have more public engagement, but maybe in a written format so that whatever their communication abilities are, we are hearing them and they feel as though everyone is seeing it and has the opportunity to hear what they say.
Great, and Charlotte, you and I talked about, in preparation for this meeting, maybe exploring reaching out to other self-advocacy groups around the state and pulling in more voices, right, of people's lived experiences. Do you want to talk anything about that?
So far in some of our groups, we've, kind of discussed some of our own personal advocacy endeavors. And I've been very proud to see how many of our members have taken that upon themselves to create their own groups or join groups. Um, this is still a new avenue for me, and so I'm learning and kind of getting a view of other people's um, ways of reaching out to the communities and advocating and all that. So, and also learning about the other members specifically to know their specific needs, whether it's documents that are only in black and white or things like that, to make sure that we have a good line of communication with everyone so that it's known and not just expected, but told.
Thank you. Any comments or questions? Teresa has her hand up. Teresa, if you'd like to share your comment or question.
Hi there, can you hear me?
Yes.
Great, thank you. I wanted to have a question about the manual feedback.
Okay.
Okay, great. So I echo some of Charlotte's concerns around the rapid turnaround time to provide feedback. And particularly, some of us were on vacation and just got the notice of the information on Monday, and it's due Friday. So I asked if there could be an extension of the feedback. That would be much appreciated. Second, most major, we were able to pull some CCS representatives together. And one of the main concerns and questions we have is that recognize that the changes are effective on October 6th. Is there any type of transition period to permit when the actual changes will go into effect? Because in essence, that's 6 weeks from now, and that seems a rather quick. Can you comment on that, please?
Sure, absolutely. A couple things about the self-directed services manual. We actually had shared the manual, I think, during the public input process, and we didn't get any comments back. So recognizing that everybody was very focused on the waiver amendment, we took the updates that we got from an external self-directed advocacy group, incorporated those that we thought would be very helpful, and then we resent it out. So it's actually, this is the second time we've sent it out from that, but we'll actually take that back and consider your suggestion. The waiver application has a glide path for several of the new provisions for October 6th. For example, individual and family directed goods and services, as per the previous legislative process, we have returned to the limit of $5,000 for what we would consider other goods and services. And so we had noted in the waiver application that individuals who've been approved already above that level will continue to be able to access those services that they had and those funding through their next, through the end of their annual plan year. So we are looking at, strategies and incorporated some of that in the waiver application to have that glide path from there. I'm absolutely interested in your suggestions or questions or concerns or any other ways we can further enhance or explain in terms of either the waiver amendment or some of the provisions related to the self-directed services manual. And before we leave, because Charlotte shared some really great information with us, just wanted to see if anybody had any comments or questions. Josh, if you'd like to share.
Wanda, I have a question for you. So, when we receive material to look over, like the amendments or any of the manual, I would like to suggest that we have more time to review the material, because including me, it's a lot of material to take in. So I would like more time to look the material over. Also, Wanda, is it possible that some of the material could be in plain language or simplified? Is that possible?
Yeah, Josh, thank you for your comments. We're absolutely always trying to do plain language. We know we have more work to do that. All of us are working on that. I want to say a big appreciation for Rachel London. We reached out to Rachel to kind of look over a letter or notice that would be going out to family supports and community supports participants to also help us with that language. So we'll continue to partner with council members and others to help support us as we look to support individuals in providing information that's plain language as best we can. The waiver application is a Medicaid application, and unfortunately it is a very big document, but we will continue to look at other ways and strategies to include condensed versions or visuals as we kind of move forward. So thank you for that feedback. We're going to continue to work on that.
Thank you, Wanda. I appreciate it. Thank you.
Thank you, Josh.
Rhonda, I just want to echo, Charlotte, your comments were fabulous, and we've heard from Charlotte and Josh, and as a council member myself, I'm asking, can we just agree to extend the deadline for a week for the public comment on the SDS manual? I feel that everybody really is asking for a little bit more time on that.
Absolutely. Yeah. So I'll send out an email just to confirm that. We'll extend it another week so that you have some additional time. And again, we want every member, every council member to look at. We want feedback from your perspective. And remember, you represent different groups, and so really have those conversations with the people that you're representing or your representation, so that you've got a really good information that can come back. Okay, so I will definitely send that out. Okay, we can go to the next slide, which is the waiver recommendation work group. Charlotte, are you reporting out, or is
Rhonda, we have Nick too.
Karen's on the phone?
Nick. You can go back.
Nick.
Rhonda, Charlotte, you want to assist? It's Rachel.
We're gonna, hang on one second. We're getting multiple problems. So Nick, our update for LTSS Maryland is available now. Is the council okay with having Nick's update, or would you like to go with the waiver recommendations? We have 10 minutes, yeah. We can go over, I mean, we're available. The recommendations first, okay, yep. And so we're gonna hold on Nick. Rachel, are you assisting, or am
I was asking if you wanted to assist. I just have the notes that I sent out from the last meeting. Okay.
All right, thank you. And I'm gonna assist, and Charlotte's gonna assist, and Rob is gonna assist. But I will start. So I wanna also thank Charlotte and Josh, because the first recommendation that we always wanna reiterate is that if we know not everything can be in plain language, and like the Medicaid application, but we do believe there are ways to provide the information that is more understandable. So for example, the summary of comments made about the waiver, it would be very helpful, and we would recommend that we review the themes and the trends and the overall concerns expressed, rather than assuming everyone on the waiver advisory council can and wants to read the, I don't even know the number of pages, but it was a lot of pages, that document, that kind of thing, while not plain language, is another way to make that more accessible. So we talked a lot about that. So I'm gonna kind of bucket our recommendations into two big things that we talked about based on the waiver amendment. And some you've heard from Rhonda, and I am going to start with the discussion about the substitute decision-making. So the subcommittee agrees that and is thankful that the supported decision-making agreement was removed from the amendment. And we absolutely agree that the needs, wants, and desires of all people who get services should be listened to. People have the right to choice and control in their lives, no matter what model of service they choose or who provides those services. We know we have to decrease any conflict of interest and make sure Maryland follows the CMS guidance. Given that, we think that the CCS and support brokers are in the best position to determine any conflicts. And we know that 3 forms already exist. Please correct me if I'm wrong on any of this, please. The 3 forms are family and staff forms, participant agreement forms, and the roles and responsibilities, or whatever the title of that one is. And instead of creating more forms, we think we need to find ways to revise the existing ones to get to meet the requirement, the CMS requirement. We also think there needs to be increased training for CCS and support brokers around decision-making processes. And perhaps there is a way to have them attest to the fact that the decisions being made are what the person wants or would want. And we did a lot of looking into different substitute decision, starting with the Maryland courts and the required training for all guardians and their standards of substitute decision making, which by law all guardians already have to follow. And if there was a way to use existing materials, so that was one of our big recommendations. We also talked a lot about training and the requirements for self-directed services training within the amendment. And if it's okay, I'll pass it to someone else for that part. Thanks.
So as it relates to the self-directed services training, the subcommittee talked a little bit about the items in the current waiver amendment regarding the modules 1 through 3 being required for all self-directed participants. We didn't know that this was wholly adequate, and so we talked about it a little bit, and we actually have 2 recommendations within this category, I guess. We thought first it might be good to create a standard presentation that includes an overview of both service models, and making sure that that's provided to all people entering services. Because if we're trying to answer the question, what does a person need to know to be successful in whichever model they choose, the best way to do that is to provide as much information about both service models as possible. And so we talked a little bit about that in the operationalization of it. And it might take some partnering with some school systems and transition teachers in order for us to be able to make that happen. But that at least gets us started on the right foot. And then the other recommendation that we had was to create a specific self-directed services training that has information that addresses what a person needs to know to be successful, such as what's involved in self-direction, what is employer authority, who's involved, the decision-making process, all of these things. That's not an exhaustive list. This would take much more thought and collaboration to come up with, but it's a starting point. And we kind of talked about, because one of our members is from an FMCS organization, and they have a really good employer handbook that can be used, and it's written in an understandable way for participants. And so it might be good for us to come together and kind of build some items out of that along and get some other feedback. And so I think, does that sum up everything related to that? Any other comments from any of the members? Okay.
Rachel, Charlotte, are there other
Is that?
No, I think we did cover that.
Great. Any questions, comments from council members? Great. Okay. Do we want to go to Nick?
Good afternoon, everyone. You able to hear me okay?
Yes.
Yes.
Great. Can we go to the next slide, please? All right. So good afternoon, everybody. My name is Nicholas Quinones. I am going to give you updates on some of the work that we've been doing with the LTSS Maryland tracking system. So in our latest release, which was on August 11th, there were a couple of updates that went out. The first one was related to our client attachment functionality within LTSS. We created some new DDA specific categories for the purposes of ensuring that DDA has the opportunity to upload and maintain documents that are pertaining to DDA and contained within DDA specific categories so that they aren't being uploaded into categories that are being used by other user groups. So we created categories for a DDA application, letters, forensic, and an archive folder for historical documents as well. As a part of that effort, we also did some data cleanup where we ran a patch to move historically uploaded documents that were put into incorrect categories over into the new DDA archive category to make sure that they were placed in the appropriate categorization. So that was the first update that we did in our August release. The next two that I'm going to touch base on relate to CCS functions directly around the person-centered plan. So the first update that we did was we now gave our CCS user group the ability to revise the most recently active person-centered plan. So what was happening previously was they only had the ability to revise a plan if it was still active, but if for some reason the individual went out of services and they needed to develop a new plan to try to get them back into services, the system was forcing the CCS to start from scratch and develop an initial plan, which was not what we wanted, not efficient. So now if a person's plan has become inactive and the CCS needs to do a revised version, they will have the ability to do so by revising the one that was the most recent active. And then the third thing that we did was, again, to help guide our CCS user group in the development of person-centered plans. We wanted to ensure that when they're developing a new plan for a person, they weren't inadvertently creating a gap in effective date ranges. So for example, let's say their last person-centered plan ended on August 15th, and they're developing a new one, and they set the effective date to be August 20th. Well, that would have created a gap in effective date ranges between those plans, which would leave the individual out of service for those gap period. So what we did was we implemented a warning message to the CCS so that when they submit the plan, if the system detects that there would be a gap in effective date ranges, it just gives them a warning saying, hey, are you sure you meant to do that, so that they can verify the information before proceeding. Now looking towards the future, our next release is actually going to be on September 8th, so in just a couple of weeks. And there are two primary projects that we're working on for that release. The first one is related to how we classify or categorize pending applicants for community pathways, family supports, and community supports. So in the last month or so, we've been investigating this information, and we found that the logic that was in place was not exactly what we wanted it to be. So we're doing an update so that LTSS knows how to appropriately determine when is somebody truly pending for one of the DDA waivers. And the way it's going to work is it's going to look specifically for the existence of a DDA waiver application packet where the MA application has been uploaded by the CCS within that packet, because those are the components that we know means that the person is now a pending applicant because the MA application has gone to EDD. So once we put that logic into place in our September release, it's going to automatically clean up data that's within LTSS Maryland to ensure that we have pure or 100% accuracy in tracking who our pending applicants are so that nobody falls through the cracks. And then the next item going into our September release relates again to CCS users and going back to our client attachment categories. So there are currently 3 specific client attachment categories that are used to communicate or share information with EDD. We were actually touching on these earlier in the meeting. And it was discovered within the last couple of months that the CCS user group was missing access to one of those categories. So the 3 categories are MA application, financial documents, and redetermination applications. But our CCS users were missing access to that redetermination application category. So we are correcting that. So starting from September, they will be able to see, view, and upload to that category so that they can upload things to the appropriate category for EDD. And as Keisha mentioned earlier in the presentation, when documents are uploaded within that category, EDD does have access to a report, a client attachments report, that they utilize to retrieve and then acknowledge the upload of those attachments. Okay, next slide, please. Now, continuing to look towards the future, the next release I'll talk about is our October 6th release. So this directly relates to what's also been discussed a few times on this call, which is the DDA waiver consolidation. The intention here is that all currently enrolled individuals in community supports and family supports will be disenrolled from those waivers and automatically enrolled into community pathways on 10/6. They will maintain their same level of service. So another thing that we're doing is we're converting their person-centered plans from CS or FS over to community pathways, and they will keep and maintain their same level of service. So there will be no extra work required by our CCS users or anybody. All of that's going to happen in an automated way within LTSS Maryland to convert over their plans. And we're also going to be taking care of any pending applicants. So all pending applicants for community supports and family supports are also automatically going to be rolled over to be called pending applicants for community pathways, and they will pick up exactly where they left off in the application process. There will be no need to start over or redo anything that was already done. They will just pick up exactly where they were in community pathways. Couple other things happening within that October release. So we are introducing a new service. So there will be a new individual and family directed goods and services day-to-day administrative support service that will be available within the Community Pathways Person-Centered Plan for selection. This is only applicable for self-directed clients. So I do want to point that out. And then we are also doing a minor update. It's just a label change to one of our existing client attachment categories where we're relabeling it from FMCS documents to self-direction documents. And then the final update is looking towards our November release. We're also going to be introducing another service, which is going to be a monthly fee for assistive technology. So that will come out in our November 2025 release. And those are all of the updates related to LTSS Maryland.
Thank you, Nick. We have a question in the room.
Thank you, Nick. One question, this is Beth Benavides. One question I had was with regard to participant access to LTSS. At one point, I think in the Self-Direction Act, it was mentioned that my LTSS would be created. Can you clarify, is that going to happen or not going to happen so that participants can have access?
Rhonda and Marlena, do you want me to kick that to you?
Yeah, we'll answer that. So great question. We are working internally to try to support that effort. There is a cost associated with creating and establishing access from my LTSS. And so, looking at our fiscal constraints and fiscal abilities, we'll continue to work towards that effort, but there is a cost with the development of that access.
And it certainly remains a priority for the department. As we are shifting our priorities, it's definitely still there.
Okay, that's
yep.
Just what perfect, thank you.
For those online, this is Deputy Secretary Hutchinson. I said that my LTSS Maryland remains a priority for the department at this time as we are shifting priorities to accommodate the supports and services for participants and also payment to providers. It has not gone absent from our attention. It remains a priority, but we're shifting things around.
Rhonda, you have one question from a.
Yeah. So I think any other questions from the council members before we open up for some public comment? Okay. Dr. Smalls, if you'd like to help facilitate the public comment.
Okay, at this time, we don't have anybody with their hand raised. Oh, here we go. First person is Ade.
Dr. Smalls, are you asking people to raise their hand?
Yes. I'm sorry.
So if you'd like to share some public comment, if you could raise your hand, and then Dr. Smalls will call on you and we'll open the line.
Yes, good afternoon, everyone. I'm Ade Abadar with Elevate Spectrum, and I have a quick question or just maybe a comment to think about. So in reviewing slide 37, it appears that CPW expenditures are nearly double those of CSW. And if participants are converted from CSW, the community supports, to community pathways, come October, will this shift place additional strain on long-term program sustainability, particularly as it expands eligibility for the higher cost community living group home service? From a policy standpoint, how do we plan to balance, or how do we balance ensuring access to community living group home for those who truly need it, while at the same time encouraging the use of less restrictive and more cost-efficient service models? So just want to, it's maybe more of a comment, except you have a response to it at this time.
Yeah, thank you so much for that comment. A few things just to note. All services are based on assessed need. And so even individuals today in the community supports waiver, if they needed residential services, they're in crisis, they meet the need, they have that need, they would now today request those services. They would have to disenroll from the community supports waiver and enroll in the community pathways waiver. So as we have said all along, we want to continue to support people's needs. It's based on assessed need. The standards are in there in the waiver program. So if they have the need for residential supports, then we would be authorizing that service and supporting them. Thank you.
Okay, our next person is Mary Jancic, and I apologize if I pronounce your name incorrectly.
Hi, I'm Polish. I'm used to getting butchered, so I don't take offense. My question is, first, apparently I have missed the entire proposed manual changes. Where can I find that?
Yep, thank you for that comment. We have shared that for input with the Waiver Advisory Council to get input related to the proposed changes. We are updating the manual to align with the self-directed services, with the waiver amendment. So if you'd like to share any additional thoughts about the existing manual, feel free to share them with the dedicated email address that we did use for the waiver amendment, which is WFD DDA at Maryland. We can share that with you if you want to send an email to us.
Okay, so that it hasn't been shared with the public, it's just been shared with the Waiver Advisory Committee?
Correct. We have shared it with the Waiver Advisory Council for input related to it.
Okay.
Okay. Our next person is Zanetta Wetzel.
Hi, thank you for letting me ask my question. Will there be a change in how agencies can do redeterminations for the waiver and other services through DDA? I know that there is a new website. However, each individual would have to have their own email address and their own phone number in order for us to apply online for them. And it would make it easier if each agency had their own logon so they can apply for all of their individuals within their company. And then the other question that I had was, will they be planning to return to the office so that when we have some questions in regards to the waiver, so that we could visit there in person to kind of talk to them about changes or things that they need before they cancel them out of the waiver?
Yeah, thank you for those questions. Your questions seem to relate to the Medicaid financial eligibility requirements for the financial redetermination. And so we heard from Keisha Shaw, the Deputy Director for Office of Elderly Services, Eligibility Determination Division, share some of those updates. So we know that our Medicaid partners are continuing to look and enhance opportunities for people to be able to submit their redetermination. Please note that participants are the center and the focus, and they are the ones who should be supported in submitting that information. We're not looking for provider agencies to submit it for all of the people that they're supporting. But we do want to support participants because, as we heard today from Charlotte and others, it's very important that we support and respect the rights, dignity, and choices of individuals and then support them in that. So thank you for those comments. Keisha, I don't know if you're on, if you wanted to add anything.
No, you covered it all. Thank you, Rhonda.
So there are no other hands raised, but there are questions in the question box. Do you want us to walk through them, or you want to look at them?
So we're going to walk through the questions. I'm going to start at the top and just go down. The first question is, when will incident reporting be transitioned to LTSS Maryland? We heard from Elisa Jones, the Office of Long-Term Services and Supports. That is part of the federal access rule that she was talking about. And so the timelines related to that are in the slide. The department would need to continue to work on that to meet that time frame. I'm just going to look at the slide to get you the date. So the incident management system must be put in place by July 9th of 2027. So the department is working internally related to that amongst all Medicaid waiver programs. The next question was on October 6th. What happens to approved plans containing elements no longer approved in the amendment? So the amendment is not taking away services. The services are still available. There may be a limit imposed, such as goods and services, but as I mentioned, there's a glide path. So if that's already authorized in your current plan, you'll continue to be able to access that through the end of your plan year. But we are not removing services from the waiver. Yep, just 1 second. There was a question about access to My LTSS Maryland, which we talked about. There's a question related to plan approvals and gaps. We heard Nick share with us that there's new functionality being supported to provide alerts so that when a plan is submitted, we don't have those gaps from that perspective. We'll take the question in the room. We'll come back to the online questions.
Thank you so much. Sherry Dexter with Concerned Citizens of SDS Maryland. I just want to echo the concerns about the updated manual. I hope that the DDA will please send that ahead of time for the community to truly review. I know when the initial manual was rolled out back in November, it caused a lot of confusion, and I will say, even personally with our family, we're still dealing with some chaos going on around some of the things that were put out. But we're still hearing from many in the community that they're still trying to figure out, even before the waiver, things from the manual that were done. At all costs, I say this from the heart, at all costs, the community wants to avoid chaos. We want to be able to give you the input, and we really would love to see, how these things from the waiver are actually going to be implemented. What's going to be in the manual? What do these forms go look like? What are these processes? There is lots and lots of concern from the community. I can say that because I've heard from dozens, if not hundreds of individuals about that. So whatever the DDA can do, I strongly, strongly ask, whatever you can put out ahead of time before it's actually in place with the updated manual, to please have the community be able to put some input beyond this advisory group. Thank you.
Great, thank you for that comment, and we appreciate your submission previously that we looked at from the concerned citizens of self-direction. So we appreciate that. Next question relates to people with lived experience group. Will this group ever have meetings in person, and will there ever be the option of town hall meetings again? Is the question. They would like to share some thoughts and opinions on some important issues affecting a sibling.
I feel that in-person meetings are definitely a possibility that we could plan in the future. We were trying to get more engagement right now, just in the virtual meetings, but I think evolving and changing to what works best for all of our members is a goal.
Thank you, Charlotte. As it relates to positive behavioral supports, what differences are there between this initiative and what is already included or incorporated in the MANT trainings? I'm going to give this over to Dr. Dee Paswell to share some information.
Sure. So in the MANT training, that is kind of a beginning discussion of what positive behavior supports is and the importance of it to have in a, having it infused into your training, your understanding, and in the day-to-day workings with the people that work with the individual that's being supported. The initiative that we have is more of a infusion of from the top down, from like the behavior support consultants and the organizations that they work with, like a top down, bringing the information in and showing them the importance of it from day one, so that the whole organization is having this understanding and bringing it forward. In our second cohort, we do have a behavior support provider that is, she works specifically with self-direction. And so when she applied, she said, right now I am a company of one, but I'm bringing in some RBTs. She was building her company. And she said, can I still be a part of the cohort? Because in cohort one, it was just traditional providers. And we said, yes, please, we want you to be a part of the cohort because we want to see how we can work with smaller providers as well as providers that work with self-direction. So bringing her in, and the two individuals that she has now that work with her have been helpful because it's been able to help us look at how we can take some of the information and adapt it for an agency that is a very small organization that works specifically with families. So this is a little bit different than what's in MAN. MAN is for families, it's for working with that one individual, where this initiative is looking at it from more of an organizational perspective, and then how to then bring it to an individual, or if that individual is living in a group home, bringing it into that group home setting.
Thank you. So as it relates to quality enhancement efforts and improvement strategies, what access do self-directing participants have to direct course and training for their staff? So we're going to give it back over to Stephanie to share her thoughts and future planning.
That is something that we're working with the University of Minnesota currently to figure out how to provide people who are self-directing access to the platform. And so that's something we'll bring to this committee at a later date.
And Stephanie, do you want to talk about some of the other things, the support broker training, case management training, maybe training for participants that we could possibly use the direct course platform?
Sure. One of the additions to the direct support course platform that is being developed is training for support brokers. The same training that they are already getting, but it's just being imported into that platform so that it can be easily tracked and things to be added to it and added to it. And the appropriate certificates delivered are able to get to the support workers. And then we're also looking at maybe making it our primary training platform for possibly coordinators of community services as well. So all those things we are discussing right now, and we'll be able to talk about further later in the year.
Thank you. And I apologize, I'm just, the way the platform is, I have to scroll down to the questions we have looked at.
While you're scrolling, I forgot the subcommittee had one more question.
Sure.
The other thing the subcommittee talked about, and we had a question was, has there been any outreach or anything done to implement the bill that passed around the Waiver Advisory Council to start in the October meeting? I would assume, I think it goes into effect October 1st.
Yeah, just for everybody's awareness, legislation was passed to add additional members to the Waiver Advisory Council, so that would be effective in October. So we will be working on that information. It's already, the legislation that was passed designates at least 3 new specific members and then expanding some of the membership, so we'll be working on that. So there's some questions related to cost neutrality. Asking related to the comparison of figures of waiver expenditures to nursing or to the intermediate care facility. Since we have 2 of them that are serving approximately 200 to 250 individuals, is that an accurate way to demonstrate cost neutrality? So as per federal requirements, we have to use an institutional level of care. For the DDA operated Medicaid waiver programs, if we shared, it is an intermediate care facility for individuals with intellectual and developmental disabilities. And so that's the institutional comparison for us. So we are required to use that. And the comparison is utilizing actual claims and then trending forward as Kristen had shared with us. So we'll continue to monitor that as we have shown in the waiver amendment and also the presentation from Kristen, there's a narrowing gap that we really need to be very aware of and continue to monitor.
And just share what cost neutrality means.
And cost neutrality, I'm going to share what Rhonda's definition and you can, okay.
And then you
Just so we're on the same page with what you want to share.
So I know that the terminology can be very intimidating. Cost neutrality means that Medicaid cannot, under the waiver authority, pay more for home and community-based services, which is what we have as programs in DDA, than it pays for institutional services. Those institutional alternatives in Maryland are Potomac Set in Western Maryland, Hagerstown, and the Holly Center in Eastern Maryland in Salisbury. So that's where our institutional participants transition from into our home and community-based services. So again, cost neutrality is the federal requirement per Code of Federal Regulations for home and community-based waiver programs is Medicaid cannot pay more for home and community-based services than it does institutional services.
And as Kristen had shared with us, those costs are actual Medicaid costs, Medicaid costs, expenditures, including any Medicaid state plan, like hospital or like doctors and pharmacies.
Okay.
Yeah. So I think at this point we're going to wrap up today. Really appreciate everybody staying extra with us. Apologize for some of the challenges that we've had. Really look forward to further dialoguing, and Rachel or others, if you want to share those specific recommendations that you were reading from, that would be great, just so we can make sure we have those. Follow-up actions, I will send out an email probably tomorrow to the council, just letting everybody know in case someone were not able to join us today. We're extending for the self-directed service delivery, for the self-directed manual. Really want to encourage members to reach out to their representation to get feedback related to that. Deputy Secretary, anything else you'd like to add?
Just want to thank you all again for your participation today. And some of the key points that really are driving home for me from what I heard in this meeting is the need for DDA to communicate more in plain language, engage the community more, and well in advance of when we are rolling out specific documents or implementing things. Another thing that I heard is basically we should provide a summary document and talk through that summary document with the Waiver Advisory Council in a way that is much more plain language than what we have to submit to CMS. And that's very helpful feedback. We'll definitely build that into our workflows and processes. I was very excited to hear the work from the work groups. Thank you so much for your time. I know that's additional time in addition to participating in this council in a very meaningful way, but then taking additional time to work in those work groups. So please know on behalf of my team and I, we really appreciate all of the work that the council and the subcommittees and the community partners who are working with the subcommittees and council. We really appreciate all that you're doing. I also heard very, very loud and clear the need for DDA to train its case managers. And so I do want to assure everyone that the department at large is actively working on training our case management entities. We have an active work plan underway, more to come from both Medicaid and DDA on that. And then last but not least, I heard very, very loud and clear about the self-directed training and how DDA can polish that a bit more to help not only just the self-directing participants, but their support teams. So I really want to thank you all for your work, the support, and please know that we're dedicated to getting through these challenges together. I know you heard the figures around cost neutrality, and I think it's resonating for some of us that we have a very, very tight compression point, but together we can work through this. And so the DDA will continue to engage our community partners. Again, we thank you for all of the time that you're putting into this work with us, and more to come in the very near future. Thanks again for coming out today.